And anybody will check, we are live on YouTube also.
अच्छा रिया, वो जो था ना वो उस पर करके देखना, तुम्हें अपने को भेज दो इसमें से
गुड
यूट्यूब
इवनिंग बकुल पारिक सर, गुड इवनिंग.
Good evening.
I think we are live on YouTube also. Karnesh, have you checked it?
कर रहे हैं, मैं भी करवा रही हूँ.
सर्वेश, हाँ सर, ओके सर.
Yes, start.
जी सर. Good evening everyone. Very warm welcome to all the participants, consultants and faculty members. We are truly delighted to have you with us today for this important academic session. Today's topic, ABC of CBC, making sense of numbers with CRP and beyond, is one that touches all of us in daily clinical practice. The complete blood count is more than just number. It's a diagnostic narrative. It whispers subtle clues, shows red flags, and sometimes shouts out systemic disease long before clinical sign appears. Yet in the rush of everyday round, we often skip past it or depend solely on automated flags, missing the deeper story it's trying to tell. Let me ask you something we have all faced as clinicians. Have you ever opened a CBC report and paused, looked at a borderline hemoglobin and wondered, should I act or just watch? Or stared at a high WBC and thought, is this infection, stress, or something more serious like leukemia? How is it that two patients with same hemoglobin can have completely different diagnoses? Why does a low platelet count in a child makes us pause? Is this dengue, ITP, or something worse? You are not alone. We all had these moments staring at lab reports, knowing there's more meaning behind the numbers, but unsure how to decide it. Because here's the truth. A CBC isn't just a test, it's a story. But it only speaks if we are ready to listen. And just like CBC, there's another test often sitting quietly beneath it on the lab report, the CRP, C-reactive protein, perhaps the most used and misunderstood inflammatory marker today. Let's be honest. What does a rich CRP truly mean in today's post-COVID world? Is a normal CRP always reassuring? How high is too high, and when do we need to act or hold back? CRP is the body's early alarm system, rising in infection, inflammation, autoimmune flare-up, traumas, or even hidden malignancies. But CRP without context can mislead, even cause unnecessary panic. During COVID, it became a compass. A CRP of 60 or 100 would make us recheck vitals, repeat scans, or start treatment early. But even now, CRP continues to play a role in pyrexia and unknown origin, MIS-C, autoimmune disorders, and treatment monitoring. So, whether CRP has been your panic button or comfort blanket, today's session invites us to look at it afresh with sharp eyes and sound clinical judgment. Because behind every CBC or CRP value is not just inflammation or anemia, but a patient, a life waiting for an informed decision. With that thought, it gives me a great pleasure to introduce our distinguished speaker for the day, Professor Dr. Bharat Agrawal sir. He is a respected figure, has served in several key national roles, including former treasurer and secretary of the Central IAP and former chairperson of the Pediatric Hemato-Oncology chapter of IAP. He is also the fellow of IAP and widely regarded for his ability to make complex clinical topics practical and easy to understand. A man of international repute and a gifted orator. Dr. Agrawal sir will take us through real-life pediatric cases and demonstrate how to interpret CBCs and CRP in ways that truly enhance our clinical decision making. Before we begin, we also deeply honored to welcome two very special guests from the Department of Pediatrics, JR Medical College, Dr. P.D. Agrawal sir and Dr. Kiran Agrawal ma'am. We sincerely thank you for being here today. Your presence greatly enriches the academic sessions and we look forward to your valuable insights. To formally begin the session, I have the privilege of inviting Professor Dr. Ajay Gaur sir, Professor and Head Department of Pediatrics, JR Medical College, to take over and conduct the proceedings. Over to you, sir.
Thank you, Karunesh, and good evening to Dr. Bharat and all the respected core committee member of this Gwalior webinar and office bearer of Gwalior Academy of Pediatrics, all the dignitaries and luminaries of the Indian Academy of Pediatrics joining this session, and all the participants who is taking time in the Sunday evening to join this webinar. I will not come between you and the speaker, and everywhere in the conference we have heard this ABC of CBC, but I know that Dr. Bharat Agrawal is the person who will do the full justice with this topic of ABC of CBC. So I'm just handing over to set the induction of today's proceeding to Dr. C.P. Bansal sir. And meanwhile, I request all the participants to be attentive in the webinar, and whatever queries or cases or anything which comes in your mind, you just write it in the chat box so that we can have the discussion at the end of the webinar. Before handing over to Dr. Bansal, let me tell you that Dr. Bansal is the figure who is taking the initiative of starting this Gwalior webinar series, and this is the third episode of the webinar, who is on the Zoom platform as well as on the this YouTube also, and a good number of the attendee, not only from the city of the Gwalior and the Madhya Pradesh, but all over India are joining. So, and he is the person who is taking lead in this. So over to Dr. Bansal sir.
Thank you, Ajay. Namaskar. My very sincere regards in the beginning to my lovely friend, mentor, brother, the star speaker of today, Bharat sir. I am extremely grateful to all luminaries which are present here, especially the man with Midas touch, we always tell, none other than Dr. Bakul Parekh, Dr. Praveen Mehta sir, Dr. Bela Verma, and Dr. Mahesh Mohite, and of course there are various other luminaries, Dr. Amit Thakkar, Dr. Deven Sareen, Dr. Beena Thomas, Dr. Krishnan, Dr. Karwa, Dr. Salman Khan, Dr. M.K. Jain, the IMA president of Madhya Pradesh, a man from Vidisha who is known for organizing conferences in IMA platform in Madhya Pradesh. In fact, it's indeed an immense pleasure to welcome you all for in episode 3 of Gwalior webinars. This is, friends, a platform that continues to grow with your enthusiasm, your questions, and of course your pursuit of excellence in pediatric care. Today's topic, ABC of CBC, making sense of numbers with CRP and more, touches the very heart of our daily pediatric decision making. As pediatricians, we often glance at a CBC and CRP report. But what if we could go beyond just looking? What if we could truly read them, decode patterns, and find early clinical signals hiding in plain sight? Be it a child with prolonged fever, suspected dengue, unexplained anemia, or a neonate who just doesn't look nice or look well, the CBC, when interpreted wisely, often whispers the diagnosis before it becomes loud and obvious. And when we pair it with markers like CRP and RDW and even subtle platelet shifts, we can refine our judgment, avoid unnecessary antibiotics, and often intervene early, sometimes saving lives and sometimes preventing overtreatment. I've started recording. And when we pair it with markers, this topic was chosen because it is simple yet not simplistic. Every pediatrician, whether in clinic, emergency, NICU, or ward, relies on CBC, yet very few of us have had the opportunity to revisit it with fresh eyes. That is why today's session is very, very special, friends. And we are really, really privileged to have with us with Professor Dr. Bharat Agrawal, a name that needs no introduction in pediatric community, a brilliant clinician, a sought after orator, and a mentor to many of us, including me across India and abroad. Dr. Bharat brings not just expertise, but clarity, depth, and a gift of simplifying complex ideas. We are truly honored by the presence of two esteemed pediatricians from GRMC alumni, Dr. Kiran Agarwal Didi and Dr. P.D. Garg sir, whose contribution to child care is deeply respected. Both hail from, currently they are settled in Delhi, all of us know. I'm also grateful to all the members of Indian Academy of Pediatrics and luminary of guests which I have just named. There are many others who have joined right now, and a truly encouraging response in YouTube as well. I also warmly each of them. We are eagerly anticipating an enriching session that will transform us into better translators of lab values and, more importantly, better bedside clinicians. As Dr. Abdul Kalam sir beautifully put in, सीखना रचनात्मकता देता है, रचनात्मकता सोच की ओर ले जाती है, सोच ज्ञान देती है, ज्ञान आपको महान बनाता है. With that, I hand over the session to Professor Ajay Gaur, who will guide us through today's program. Thank you so much.
Thank you, Dr. Bansal sir, for setting the stage for our speaker, and many of us knows our distinguished guest today, Dr. Kiran and Dr. P.D. Garg sir. But I think the best person to introduce them is Dr. Shubhanga, who is, I think, the batchmate of Dr. P.D. Garg sir. Am I right, sir? Hello, Dr. Banga sir.
Banga sir, you are muted.
Please unmute. Dr. Banga, please unmute.
Yes, thank you, ma'am.
Am I right, Banga sir?
जब बड़े बड़े लोग बोलते हैं तो बाकी लोगों का मुंह बंद हो जाता है वैसे ही.
Dr. P.D. Garg sir is your batchmate sir or your junior?
Yes, Dr. P.D. Garg is my batchmate. हम लोगों ने बहुत सारी ड्यूटीज साथ साथ की हैं और बहुत बार साथ साथ चाय पीने बाहर जाते थे.
Okay, so I think you will be the best person to introduce Dr. Kiran Agrawal and Dr. Garg.
Yes, thank you. Dr. P.D. Garg is my batchmate. We are from batch 72. He was from a small city, Shivpuri, and went straight to the capital of India, established himself as a very senior pediatrician. He's presently a senior visiting consultant to Max Super Specialty Vaishali. He used to be HOD in that hospital. He was director of Pushpanjali Crossley Hospital. He has been president of IMA East Delhi branch in 2004 and 5. and presently is Director of Clinical Diagnostics Center and visiting consultant to not only Max but some other hospitals also. It's very well established in Delhi, and we are happy to see him today on our platform. Dr. Kiran Agrawal does not need any introduction. Everybody in this country knows her. But even I didn't know that she belongs to Gwalior. Because we are very junior to her. She's from 68 batch. Mrs. Shingvekar is her batchmate, so we can think how senior she is. And she was known as a captain of GRMC badminton team in her time. Many old people will remember her like that. Now she became president of Delhi IMA, but that's a very small achievement for her.
No,
Then she became
IAP.
IAP, right?
IAP.
And
Delhi.
she has been EB member of IAP, but she has done much bigger things than that. She has worked as a pediatrician in 4 countries, India, UK, Libya, and Vienna. But after coming to India, she has been very active with the children in difficulties. She has created a cancer group, and she has been secretary of that group for continuous 6 years. So all the issues with children, child neglect, abuse, sexual abuse, any abuse, child labor, and all those things, she has always been working on those issues, whether in office or not in office. Her name is very well connected to the establishment of POCSO Act in India, making the legal provisions, enacting it in different parts, and now she is working in various committees supervising the things that is happening over there. She has been in ICMR committees. She has been in WHO guideline, making WHO guidelines on deworming and enacting that program throughout the country. This year, she has achieved Lifetime Achievement Award from IAP as a Social Champion Award. Her work is very well known, and even at this stage of her life, she is still very active. She's writing, she's speaking on different forums, and still working in different government committees. So we welcome you, Kiran Madam. We are happy and we are proud to say that you belong to Gwalior.
Thank you, Dr. Banga sir, and very impressive biodata indeed of Kiran Madam and PD Garg sir, and we all GRMCN belongs to the School of Pediatrics of Belapurkar sir and Shingvekar sir, I think so. And whenever I am meeting Madam is always asking about the Shingvekar sir and Madam Shingvekar. I think that is the reason, because Madam belongs to the Mrs. Shingvekar batch. Okay. So I think the equally impressive is our speaker today, and one of the core committee member, Dr. Anand Ketkar of Gwalior webinar, will introduce our formal introduction of the our speaker, Dr. Bharat Agrawal. Dr. Ketkar sir.
Thank you, Ajay. Dr. Karunesh as well as Dr. C.P. Bansal has said few words about him, but that is not sufficient. I think he needs more elaboration of his personality as it is. So I'm just trying to add few things. It's my privilege to introduce eminent and distinguished personalities of IAP, Dr. Bharat Agrawal. He has pivotal role in shaping hemato-oncology through his leadership and academic contribution. If I narrate all his contributions, I think I will exceed his time of allocation to the talk. So in short, just I would want to introduce him, that he is Emeritus Professor and formal head of the department, Hemato-Oncology, Wadia Children's Hospital, Mumbai. In IAP, he held almost all prestigious posts to his credit as chairperson, head hematology, pediatric hemato-oncology chapter, treasurer and Secretary IAP, awarded fellowship in 2017, and at international level, he is Honorary General Secretary SIOP, that is International Society of Pediatric Oncology, from 2005 to 2011. He has contributed extensively in academics, in state, national, and international level. His honors are, he is a guest faculty in almost all over the India, in symposias, workshops, and as a speaker. But special to mention is in 22nd International Congress in Amsterdam. He is a speaker for various prestigious orations like R.V. Lokeshwar, Athawale Research Foundation, and more to his feather, to add to feather to his cap, Japanese Foundation for Multidisciplinary Treatment of Cancer in Japan. He has extensively contributed in publications as in academic literature also. He has more than 200 publications in the form of peer reviewers in books, journals, and conference extracts. He is associated editor of Archives of Disease in Children, Pediatric Blood Cancer, Indian Pediatrics, ISAJP, and many other journals. Sir, I welcome you for your talk to this webinar. Thank you.
Sir, just one thing I will like to add about Bharat, sir. Apart from his excellence in hemato-oncology, he is a very good athlete himself. Running is his passion, and wherever he goes to deliver lecture, he carries his pair of shoes for jogging. When he visited Gwalior, I fondly remember that he went to fort and he tried his level best to persuade me and prevent me and tell me that CP, you must run. You are living at a location which is like a paradise. But I couldn't follow that, and ultimately I landed into knee replacement. Thank you, sir. Thank you so much, Bharat, sir.
Good evening to all of you.
Okay, thank you, Dr. Ketkar, sir. So without, oh sorry.
Yeah.
Yes, Dr. Bharat.
Can I go on?
Yes, sir.
Yeah.
Without wasting time, I think it's your turn now, and you start with your presentation, and meanwhile, we will have the question answer in the chat box.
Right.
Over to Dr. Bharat.
Thank you. So, first of all, I'm really delighted that Gwalior has invited me for this webinar because I recollect, as CP just mentioned, the first time that I went out as a speaker outside of Mumbai was to Gwalior, and that was on the invitation of Dr. CP Bansal, and that I recollect is almost 25 years ago, maybe, when CPG was the secretary or president of the Gwalior unit of IAP, and it was really fantastic. As I visited Gwalior, I still remember that's my maiden visit. Actually, I have not gone there again, but I still have the memories of the fort and the Gwalior fort and the run upstairs. So it's really thrilling. I want to compliment the Gwalior branch for having this program. It's really nice that you have this program on a Sunday, because many other programs happen pretty late in the night, and it's disturbs the family life, which I don't appreciate. So I feel that having this program in the middle of the day, at some point, some people who are free on Sundays can definitely join. So it's definitely a useful thing to have this kind of webinar, which is also broadcast on the YouTube channel, and then people can always go back and check out what if they have missed something about the presentation. I want to compliment so many people who are here on this webinar. I thought I'm going to speak to Gwalior and Madhya Pradesh, but there are many from my friends from Mumbai and Navi Mumbai here, whom I'm very surprised to see. Dr. Mahesh Mohite, Dr. Bakul Parekh, Dr. Behla Verma. Least expected that you all will be here for this session. Anyway, let's move on. I want to also acknowledge the presence of senior members from Gwalior as well as from the rest of India who are present today. Dr. P.D. Garg, Dr. Kiran Agrawal, Dr. M.K. Jain, Dr. Ashok Banga, and so many others who are, I can see we have almost crossed more than 50 attendees, which is a great thing for a seminar of Gwalior IIT. So congratulations. So now coming to my topic, what I plan to do is stick to some case scenarios, allow you to think, and maybe have some question answers, more time for question answers at the end of the talk. So I think that should be the tone to set this. I wouldn't call it a lecture. I would rather want to call it more like a interaction if possible. Let's see how it goes. So I always say that CBC is a bargain. So I'm trying to screen that. Slides visible?
Yes, sir, visible.
Okay. So I always say that CBC is the commonest test that we order, but we are not really gathering all the information that is necessary or that can be gathered from this simple test. It costs very little, 150 to 200 rupees, and with the automated cell analyzers, there's a lot of information that we can gather from this test. I'm going to throw open this first patient, 6 years old female, fever for 4 days, very common scenario, high grade. Now with this season, we have so many times such cases coming to us. No other significant symptoms. And on examination, almost nothing found. No pallor, lymph nodes, liver, spleen, petechiae, nothing actually clinically. And a CBC done on the third day showed a hemoglobin of 10.8, platelet count of 160,000. WBC count 6,400, polys 22, lymphocytes 68, monocytes 2, and eosinophils, monocytes 4 and eosinophils 2. And the other tests also were run, but that was negative. So from this clinical scenario, does anything strike you? Since we are on the topic of CBC, I am focusing more on that aspect. So when you focus on the CBC, does anything strike you here? I will not wait for the answers. What is relevant here is that the poly count, which is 22% out of 6,400, does appear to be on the lower side. There is a relatively shift towards lymphocytes, but we can argue that at the age of 6 years, it may be appropriate. More often, such a presentation is likely to be a viral infection, but most of the viral infections, excepting dengue, would subside by now. And that is something which we have to keep in mind, but platelet count is normal. This child was treated as enteric fever with oral cefixime, and then on follow-up, in 3 days, the fever sort of started to move down, but not disappeared completely. So the pediatrician, being worried about it, checked for the CBC again and found that hemoglobin is 10.1, platelets borderline 1,48,000. Again, WBC, the almost similar 5,800, polymorphs 14%, lymphocytes 72, and here they found also some atypical lymphocytes 5%. Also, monocytes were 6% and eosinophils 3%. So now the thought at this point is, are we worried or are we happy? Clinically, yes, we are happy because the child seems to be improving. The fever is less. But if you see the hematological aspect, the absolute neutrophil count has dropped from the 4th day, which was around 1400, to around 800 on the 7th day. This is almost a 50% drop, which is definitely not acceptable, and one has to be really worried about this drop. Also, we find atypical lymphocytes 5% on the peripheral smear. The blasts are not seen, platelets are borderline. So whether this is again viral, whether empiric fever doesn't give rise to such low neutrophil counts, platelets doesn't start dropping. So more likely that it is viral. By this time, we had the blood culture also negative. So can we, question again, I'm posing to our audience, can we feel safe and leave this child alone? How many of you would think that we could leave this child alone?
Can't leave this. Can't leave.
Absolutely.
No.
That's definitely, you know, if the hemoglobin had dropped from 12 grams to 6 grams, you would have been very alarmed. But here, the hemoglobin and platelets are more or less steady, but the neutrophil count has dropped by almost 50%. So that's the point that I'm trying to make here, that we have to check on follow-up on a maybe not on a daily basis, but at least twice a week, and see what's the trend. So here you can see that the trend is from day 4 to day 7. There are the ANC has dropped, but again on day 9, when we repeat the ANC, it jumps back to 3600, which is very typical of a viral disease. So this is again proof that if you are paying attention to your blood counts, you don't need to rush with more intensive testing or workup of the patients. Here we have a child who was clinically better, so we could afford to wait for a day or two, repeat a CBC and see what is the trend. And the trend shows that the neutrophil count has gone up back to almost normal. Cutoff would be 1500, so we have crossed that within 2 days. And we'll see in a minute how that happens. A follow-up count few days later remained almost normal. Even you can see the platelets also have come to normal. So this case, what it teaches us is that CBC is a very extensive workup. We are actually checking for 3 cell lines: red blood cells, white blood cells, and platelets. In red blood cells, we have size, color, and shape. So we have indices, counts, and RDW. What is also important in RBC evaluation is the reticulocyte count. So very often we miss this part. What this is showing is the number of normal red cells compared to the number of young red cells. And why do we want to know that? Because young red cells reflect whether the production is happening well or not. It's a very good parameter to check. And now many of these automated machines give you this parameter. Also on the machine printout report. The other, what is marked in white is the morphology. So morphology for red blood cells, for white blood cells, and for platelets, all 3 has to be checked by a good either technician who's experienced or by your pathologist. And unless and until we ask for the details, we don't know these details. Unless and until we provide clinical information to the pathologist, they also may not know what to look for. And therefore, it is very important to communicate. So morphology is outside our purview, I would say, but extremely important part of the CBC test. So what we get on the machine printout is what is marked in yellow. So for WBCs, we can get WBC count and the differential cell count. For platelets, we can again get the counts and the mean platelet volume. We'll see how mean platelet volume is relevant or important. But I want to dissect this into two columns. So the yellow column is what you will see on the machine report, on the blood count report, while morphology is what the pathologist will see or your expert experienced technician will see, provided you give him good clinical information. So I think that is also equally important, which is necessary for us to take care of. I'll quickly, one or two technical points, just to make it interesting. I will not spend much here. If you see the red cell turnover, almost 2.5 million red cells are removed per second in an adult. And the production of red cells is phenomenal. Almost 200 billion red cells are produced per day. Yet the count in your peripheral blood remains almost tight, 4 to 5 million. So it's a very delicate balance between production, destruction, and maintenance of the red cell count and the hemoglobin levels. So this we have to keep in mind, because there is a lot of fluctuation because of this. There is more fluctuation in case of neutrophils and monocytes. Why? Because they have a shorter half-life, and in the bone marrow, there is a lot of marrow compartment, or what we also call a storage compartment. While in the peripheral blood, it is very little, almost 1/5 of what is there in the rest of the body. So what you are measuring on CBC is only this vascular compartment, not this. And therefore, when there is rapid shift because of disease or because of illness, there is rapid changes, and blood counts, especially neutrophils, can change within hours. So we have to be aware of that. Very similarly for monocytes, I will not go into the details of that. Now let's come to the crux. You get a report like this. There are now, this has around 10 parameters. RBC parameters about 6, then platelet parameters 3, and then another lymphocyte differential parameters. So we can get now up to 16 or 18 parameter analysis. But of course, it depends on the technology and the quality of the instrument that you have. There are some instruments which cannot be relied upon to give you this whole thing. So I'll run through quickly. What is done is actually from a negative electrode through a aperture, each cell is passed towards a positive electrode. That's it. So we are counting as they pass from this hole, and we record the number as well as the size. So we have, for recording the size, we have the red cell aperture, and for recording the white cell, we have the white cell aperture. So this is a little bigger because, as you know, white cells are a little bigger in size. Now, this red cell aperture is also used for platelet count. Remember that. There is no separate hole for counting the platelets. The same red cell. So if there are very small red cells like microcytic red cells, they can get counted as platelets. We'll see one example in when I come in the later part of the talk. So what is actually measured through this red cell aperture? We measure the red blood cell count and red blood cell size or volume. Through the same aperture, we also measure platelets, number and size. And then we measure through this WBC, the WBC number and size. And then all the rest are calculated. So you can see that what machine is actually measuring is only this. And like we say, garbage in, garbage out. If there is a problem in your sample, then all these things can change. And then if these things change, then all these also parameters which are calculated on the basis of these will change. So we have to be aware of what false errors can happen in instrumentation. I just mentioned this, that the machine just counts each cell. So the height is the size of the cell, and then each line represents one count. And then this is rearranged into a thing called histogram. So what we see, what we saw previously is this RBC histogram. Basically all small cells on left side and the larger ones on the right side. And then when you take the mean, that is the MCV, mean corpuscular volume, which is the peak of this histogram. And RDW is nothing but the width of this histogram. So how wide is the sizing of the red blood cells. And similarly, for WBCs, we have these lymphocytes, monocytes, and granulocytes based on their size. The machine doesn't recognize these cells. Only on the basis of size, they are segregated. And that's how we get the percentage. So this percentage sometimes may be fallacious in the sense that if the mononuclear monocyte cells are mixing with lymphocytes, or if granulocytes are mixing here, then these numbers may go up, or these numbers may go up. Or if there are blast cells, then these numbers will go up. So we have to be aware. The machine is not a final answer. We have to look at the morphology. Now let's come, as I said, to some case scenarios. We'll initially focus on MCV and RDW. Before I move, I need to mention about the age specificity. This, as pediatricians, we all know that term babies have values which are at least red cell values which are much higher than the other older age group. Similarly, look at the MCV. MCV is also quite high when you compare with older kids, which is around 80. And this is almost more than 100. Reticulocyte count can be high at birth. And also you can have presence of nucleated red cells in term and as well as preterm neonates. Platelet count is more or less normal throughout the age group. So we have to remember these changes, and therefore the practice in neonatology will be variable because of these modifications that happen with age. This is again demonstrating how in term infants there is a physiological drop in hemoglobin over the first 3 months, which is exaggerated in preterm infants because it comes much earlier at around 6 weeks. And it can be much more deeper also as compared to term infants. The second part is showing the reticulocyte, which is exactly opposite of what the hemoglobin value is. Now, what is RDW? I already mentioned to you that RDW is nothing but the width of this RBC histogram. And this width is calculated. So it is basically a machine calculation, but it's very useful for our clinical practice. So when you have a low MCV, which is microcytic anemia, and you have a high RDW, very easily, just on the basis of CBC, we can diagnose iron deficiency anemia. Similarly, which is very common and which we need to know. Similarly, if you have high MCV and high RDW, then you can immediately diagnose folate B12 deficiency. So the two common deficiency anemias can be simply diagnosed just on careful attention to the low hemoglobin. If you have low hemoglobin, watch your MCV. If you have low MCV, watch the RDW and see if it is high, then you can easily make a diagnosis. In thalassemia carrier, beta thalassemia carrier, you will have a normal RDW. So that's how we distinguish. But again, remember, not beta thalassemia disease. Beta thalassemia disease child will obviously clinically present differently and will have a high RDW. So this is a very useful way to distinguish between causes of common causes of deficiency anemia. Let's look at this. Here we have a child with hemoglobin 6.9, MCV 55, and RDW 28. I just mentioned to you, this is typical iron deficiency anemia just on the basis of these three parameters. Platelet count is high, which can be expected. With iron deficiency, you can have thrombocytosis. And so this is microcytic hypochromic anemia, high RDW, low RBC count, thrombocytosis. This is a typical picture of iron deficiency anemia with hypochromic microcytic anemia. And it's not necessary to do ferritin levels. This was done in this child and found to be 2, which is anything below 15 or 16 would be significant. So therefore, but it's not really necessary to do any more tests. So you need as a clinician, you can check this, and then the pathologist has to report these findings. This is not in our hands. So we need to check with the pathologist also. And this is simple iron deficiency. Let's look at another case. Here we have a RBC count, which is 6 million, definitely high. hemoglobin 12.7, more or less normal. MCV is very low, 63, and RDW is almost normal, 15. Platelet count is normal. So we just discussed this, that you have severe microcytosis and hypochromia, severe, but RDW is normal. And there is a raised RBC count with almost a normal hemoglobin. And this is a typical hemoglobin electrophoresis pattern, which you see here, the raised hemoglobin A2 levels. So this is 5.6% hemoglobin A2. This is typical picture of beta thalassemia carrier status. So it's very obvious just on the basis of these few parameters. If you pay attention, you don't need a pathologist or a hematologist to make that conclusion for you. I mentioned about reticulocyte count, which is again a very good parameter to have in your armamentarium. And this will impress upon you why this is so important. This girl had pallor for running for almost 3 years. Multiple investigations, multiple pediatricians. Mild icterus, liver was just palpable. Spleen 3 centimeters. On testing, hemoglobin was 6.5, reticulocyte count 7%. Now, you remember, reticulocyte requires a correction to the degree of anemia. I will not go into that details, but it's necessary because as you are anemic, more young red cells are thrown out. So you need a little correction. But even after correction, 7% is pretty high. The other indices are almost normal. WBC count, platelets is normal. And here, the importance of morphology and reticulocyte count both in combination, that we could make a diagnosis. This is the photograph of this girl, and this typical spherocytic cells. You can see not all cells are spherocytic. So this is a normal RBC. This is a spherocytic RBC. You can see around 30 or 40% of cells are spherocytic, not all. So this is how we can easily make a diagnosis of spherocytosis on peripheral smear. And then when we checked, the father had undergone splenectomy. That history was discovered after the smear was done. So this is again proper clinical importance of proper clinical history and recording the details. One very useful parameter that is available to us in the machine printout is called MCHC. MCHC is a measure of the cellular hydration. The normal is up to 34, and in spherocytosis it goes above 36. So yeah. So in sickle cell also it goes up. So again here MCHC and other parameters will help to make a diagnosis. You can see here in this report the hemoglobin 14.8 and NCFC is 36.5. So this is a classical autoimmune hemolytic anemia where the hemoglobin is being maintained, but the MCHC is high. So that's how we get these type of spherocytic cells in autoimmune. So we get spherocytic cells also in autoimmune hemolytic anemias. Now coming to ANC, that was my case in the beginning, and that's very again important to know that as the age advances, the proportion of neutrophils to lymphocytes changes. What I want to emphasize is the last column, this monocytes. This monocytes has come, these are all the number of monocytes. You can see that in early life, we have big number of monocytes, and they are definitely normal, not abnormal. If you have atypical lymphocytes, like in our first case, that we have to be careful about. So how do we calculate absolute neutrophil count? It's very simple. Most of the machine printouts now provide this detail. But if it is not provided, you can just simply calculate the percentage of neutrophils into total WBC count divided by 100. What is APC? APC is nothing but neutrophils plus monocytes. So actually, this is a useful parameter when we have immunodeficiency or other illnesses where the neutrophil counts are pretty low. Especially in febrile neutropenia, for recovery, we look at APC rather than ANC. Now, this is again a common presentation. fever for about 20 days, generalized moderate lymph nodes, mild liver spleen, no pallor or icterus, 3-year-old girl. Hemoglobin 11 grams, retic count is normal. Other indices look normal, RDW is normal. The platelet count is low, 1,20,000, and WBC count is on the higher side, 28,000, with some abnormal WBCs. The question here was, should we go ahead with the bone marrow examination or not? Because you have at least 2 cell lines which are affected, and you have a clinical picture which is showing lymphadenopathy and hepatosplenomegaly. So that's a big question. So here again, this is the kid. It's very important to look at the peripheral smear. So here, whatever depth you go into the CBC report, unless and until you have a good pathologist who is able to differentiate those cells for you, it's difficult. So the question of whether to do bone marrow or not depends on this peripheral blood smear report. Here, I can very confidently say that these are the atypical lymphocytes which are visible on the smear, and therefore there is no need to do a bone marrow test. But if these cells were not visible or available, then it's difficult, and then it would be always safer to do a bone marrow rather than err on the wrong side, because diagnosing leukemia is very important rather than missing it and delaying the treatment. In this case, actually, I can show you the follow-up. The WBC count on the day that we diagnosed clinically, then it almost came down to normal in 2 weeks. And if you can see, the number of atypical lymphocytes was 64%, which dropped down to 4 in 2 weeks. And the point here is, which is against leukemia, is the absolute neutrophil count. So in leukemia, you will have a high WBC count, but also a low ANC. So you have a high WBC count, decreased number of neutrophils, and low ANC and decreased platelets. So you have a kind of pancytopenia, while this ANC is above the cutoff limits, and therefore we are in the safe zone. We have atypical lymphocytes in profusion, like this child, infectious mononucleosis. We can get this with even cytomegalovirus. Even simple viral hepatitis A can cause this in the pre-icteric phase. Measles, adenovirus, echovirus. So just remember that you can have a lot of atypical lymphocytes in the peripheral blood. It's not leukemia. Look at the neutrophils. If you have a ANC above 1500, 2000, you are in the safe zone. Let's come to platelets quickly. I think this is a very confusing parameter, but again, I want to point out that we must look at least these two, platelet count, and learn to look at MPV, that is mean platelet volume. This is the same as what we did for RBCs, that is the MCV, this middle line. So MPV tells you that where do you stand, what is the size of the platelets, and that's very useful. This is a child who came for purpura for 5 days. Hemoglobin was 4.9. There was no internal bleeding actually, which we could detect, but this is how the child presented. Retic count was slightly high. MCH and parameters were, the RDW was elevated. So when you put this together, the MCV, RDW, there is some underlying iron deficiency we can say that this child has. WBC count is normal and platelet is 2.5 lakhs. Now, in a child with bruises like this, obvious bruises clinically, you can see on the face also, to find a platelet count of 2.5 lakhs was little off the mark. So what we do the peripheral smear examination, and it says absent platelets. So then how do you explain? This is a difference between the morphology as well as the machine, and that's because of the iron deficiency anemia. I explained that in the beginning, that platelets are counted through the red blood cell aperture. So these microcytes, micro RBCs, are counted as platelets, and therefore, even though platelets are absent, you have a platelet count of around 2 lakhs. So that's a little more complex situation, but very easy to make out. And the diagnosis was very clear-cut in this child with acute ITP and iron deficiency anemia. So we always observe the numbers as well as size. In ITP, usually the platelets are large in size, so your MPV will be larger. And when we find about 1 platelet per oil field, it's approximately 10,000. And this is what happened in that child, where you have these microcytic red cells which overlap with the platelets, and therefore you get a little higher platelet count. One thing which you have to remember about platelets is sampling. We usually do platelets with EDTA, most of our CBC samples, but EDTA can sometimes cause clumping, like in this sample. So here the platelet count is 47,000. Again, when we check the smear, it looks adequate, and the sampling done with citrate shows a value of 1,74,000. This is just to highlight that, sampling errors can also be there in your CBC result, and one has to be aware about those. So you can have a low platelet count because of a clot or because of clumping due to EDTA. Sometimes high platelet count, as we saw, because of RBC fragments, overheating, or iron deficiency anemia. And remedies, of course, to check the peripheral smear. Now, coming to peripheral smear, I don't think any of us would spend time under the microscope, but we can definitely insist on our pathologists to be more alert and careful. And definitely a lot of problems can be detected. For example, this is severe iron deficiency anemia. This is a typical picture of thalassemia major. This is sickle cell anemia. This is Cabot ring, like what we find in megaloblastic anemia. So these are actually very typical diagnostic features. But unless and until the pathologist is careful, they can be missed. This is, I already showed you, spherocytosis. This is acanthocytes, what we get in HUS. Sometimes we have to ask the pathologist to look for such cells, and they can be detected and counted also. And these are the target cells that we get in other hemoglobinopathies. This is what we find in G6PD deficiency called Heinz bodies. So even before you run the G6PD enzyme assay, you can make a diagnosis on the smear. But very few people are now really looking at smears until it is asked for. These are nucleated red cells. This is very typical blast cells. I showed you the infectious mononucleosis with atypical lymphocytes. Compare that with this blast cell, there is hardly any cytoplasm. So this is very typical and very easy to identify by an experienced eye. So what I want to impress upon all of you before we move on to question answers is, keep in mind normal variations. According to age, there are variations which we must be aware of. Then there are sampling errors, which I pointed out to you, which we have to be also alert about. And the third thing that I want to emphasize is the importance of follow-up. So because CBC is dynamic and keeps changing because of the kinetics of red cells, neutrophils, monocytes, it's very important to follow up and see what's cooking. I end by saying that CBC is a bargain. I'm sure there'll be many more questions because I can't cover the whole topic in such a short time. So let's leave it for case scenarios and questions. And I can tell you that Dr. Bansal has a lot of questions which even were bumper for me. So let's move with the questions. Thank you.
Sir, we don't have any bumpers. How can we give bouncers or bumpers or googlies to Sachin Tendulkar?
Stop sharing.
Thank you. Thank you, sir, for enlightening us for a very basic but the very useful talk. In fact, we are seeing, we means many of the pediatricians seeing the CBC report very casually, and nowadays the pathological labs are also highlighting to make our job more easier and giving the interpretation page also. Some of the pathology labs are giving the one-page summary also.
Yes,
sir,
don't depend upon that. You do your own interpretation.
Yes, sir. That is the reason. That's why I told you that many of us, not all. So it's a very, very wonderful basic lecture, and really it's a ABC of the CBC. And on the ABC, then you can build up whatever you want, or whatever you want to
So
go
I
to
have just
inside.
touched upon very few points. I have not covered exhaustively,
Yes, sir.
but maybe through question
Yes,
answers
sir.
we can address.
Yes, sir, definitely. We have a lot of questions for you from our esteemed members also. But before that, there is one A very basic question is in the chat box from Dr. Jain, that whether there is some difference of the CBC report in the if you are doing manually and if you are doing by the analyzer.
Very good question. Manually is what was done till 25 years ago. Now there is no place for manual in our practice because manual is not precise, is not repeatable, it is not accurate, except for morphology. So there is no question about doing all these, what I mentioned about cell number, size, color, all that, except for morphology. The rest of the counting must be done on a cell counter because they run through microliter sample and they are much more accurate, much more precise.
Yes, sir. Sir, but for platelets, there was some debate going on that if you are doing with the analyzer and if you are doing there are some megakaryocytes which are not counted by the analyzer. Is it a true statement, or we have to check it again with the manual?
No,
megakaryocytes.
One second. Megakaryocytes are present in the bone marrow. So in the CBC, you don't find megakaryocytes. Platelets. So
Yeah.
platelets, of course, I mentioned to you that the RBCs and platelets are counted through the same hole. So if there is a overlap in size, the machine cannot differentiate. You know, the machine cannot tell RBC versus platelets. It only knows by the size. So that is why when you have a discrepancy, it is very important to do the peripheral smear examination, morphology examination, which is not done by us. So that is the problem. We are dependent on another expert, but that we must demand.
Yes, sir. So there is one more question in the chat box is regarding the bicytopenia. So if the child is having the bicytopenia, how should we approach to this case?
So bicytopenia is multiple reasons. It can be poor production, excessive consumption. So it all depends on the clinical status. It's, you know, you will get bicytopenia even in DIC because of excessive consumption. But the clinical scenario will be so much different. So you cannot generalize. You need to know the clinical status of what direction you are healing. I showed you one patient with bicytopenia where bone marrow examination was asked for, but we could avoid because there were no abnormal cells. What we found was all atypical lymphocytes. So we did not go ahead with doing the bone marrow examination. So bicytopenia is, I would say, a red flag to be followed up. If it recovers, well and good. If it doesn't, then we have to investigate.
Yes, sir. Yes, sir. And so clinically and history,
yeah,
is one should correlate with the bicytopenia, I think. So, okay. So as the others are writing on chat box, may I invite you, Dr. Ketkar? It's a very big 2-3 question which you are writing. So can you ask directly to Dr. Bharat? Dr. Ketkar, sir? Dr. Ketkar, sir. He has written the role of the ESR and CRP and in the suspected infection or the chronic disease. The role of the ESR, in fact, he wants to know along with the CRP.
Yeah, so let me break it up. ESR is a useful, or rather has been a useful tool for various things, for diagnosis, for screening, for monitoring, for treatment response, for various things. In fact, you'd be surprised to know that 100 years ago when ESR was described, it was 100 years ago when ESR was described, it was used as a pregnancy test because in pregnancy also the ESR goes up. So ESR is pretty non-specific but definitely useful, especially for monitoring purposes, and it has a lot of variables. What is ESR? ESR is erythrocyte sedimentation rate. So you actually put in a Westergren tube, you put 200 microliters of blood and then you allow it to settle, and at the end of 1 hour you see how much is settled. But that how much RBC settle depends on the size and nature of RBC, depends on what plasma proteins are there or not, depends on many other factors. And based on that, you will have a variation. Most often with inflammation.
We have many more factors now.
Yeah.
In yesterday year, we had just ESR with us. Now we have CRP. We have many more parameters.
Absolutely. That's why
the chronic marker of chronic disease, and we have so many factors.
So there is in certain places like collagen vascular disorders, ESR has a better place for monitoring than even CRP. So there are advantages of both, and one can definitely use both judiciously. So that is my take on ESR. CRP is definitely a very important tool for pediatric practice because of the acute nature. The rise of CRP happens within about 6 to 8 hours. Excuse me, I'll just get some water. CRP is definitely
Sir. I think he is going, I think, for a glass of water.
Glass of water, yeah.
Speaking since our he is back now. Are you okay, sir?
Again, it is a inflammatory marker.
Okay.
Sir, how do you explain the utility of ESR plus CRP and other markers, infectious?
See, I'll make it very simple. In response to infection or inflammation or injury, any of these three, you will get an acute phase reaction. What we are measuring by CRP is an immune reaction. CRP is a C-reactive protein which is produced by the liver within 6 to 8 hours of any of these three. It may be inflammation, infection, or injury. You can say 3 I's. So all these three will lead to a rise in CRP. They will also lead to a rise in ESR. But the timeline is different. The timeline for CRP is 6 to 8 hours. The timeline for ESR is 48 hours. And so you can use both in combination. And when you're faced with a child with acute febrile illness, CRP is the one which will help you, not ESR, because of the timeline. I saw in the chat Mahesh has written CRP is IL-6 surrogate, ESR is fibrinogen. I would say yes, but ESR is even much more than fibrinogen, not just fibrinogen. I'll take a break 1 second.
Sir, you take rest for 2-3 minutes. Meanwhile, yes, sir. That's why. Because if you are,
sir, have some warm water, sir.
Or,
just have some warm water.
Yes.
And rest.
Yes. Good evening.
Good evening, sir.
Dr. Bela, madam.
Yes, sir. Good evening.
No, I am fine.
Yes. Okay. Are you okay, sir?
Absolutely.
Okay. So you continue, sir, with this, and meanwhile, you can take the surrogates also, the procalcitonin. There are a lot of questions also. So you can take all the questions simultaneously. CRP alone, CRP with ESR, some surrogates, the procalcitonin,
so
and serum amyloid level also nowadays is very fascinating in new.
As I just mentioned little while earlier.
Screening. So you can take all, sir, in one.
Yeah.
Yes, sir.
All are acute phase reactants. What is the meaning of acute phase reactant? Is in response to infection, inflammation, foreign body or injury or tissue death. All these acute phase reactants will start rising. Of these, procalcitonin is most reliable test, but very expensive. So we limit the use in general clinical practice. Every child who comes with febrile illness, you don't want to do procalcitonin, but you might do CBC and CRP. So that's how we prioritize. For a neonate, definitely procalcitonin could be considered as one of the initial investigation if you're suspecting severe neonatal sepsis. And ESR is so non-specific, also, as I mentioned, late in rising, so therefore not that relevant in terms of our clinical practice today, I would say. But it is very useful in monitoring chronic diseases, because CRP may remain elevated and may not be that useful in cases of chronic diseases.
Okay, sir. We have one more question, that can we monitor our induction of antibiotic and upgrade or low grade the antibiotic just on the basis of CRP values? It's a question in the chat box, sir.
Yeah, I don't think that is justified at all. I would say that there is one study on CRP which I had come across especially for neonates, where if you find that two consecutive values of CRP are less than 10 milligrams, then the chances of sepsis are pretty low. And therefore, you can, on that basis, discontinue the antibiotics. So that's one message which we can keep in mind. But again, it's a pairing. You have not one single value, but you have at least one follow-up value within 24 hours, which says that the CRP is the difference is it's not difference more than 10 milligrams.
Okay, so do you mean the CRP velocity?
Yeah, the change in CRP value.
Yes, sir. We are working on that, the CRP value, that how it changes with the day 1, day 2, day 3 in a septic case.
So CRP half-life is
early
around
onset sepsis. We are doing this study in
48
Gwalior
hours.
itself.
The
Yes, sir.
half-life
Yes,
of
sir.
CRP is about 48 hours. So you will have depending on how soon the infection or inflammation is controlled, you will have some change. So it also depends on the etiological factor. It's not
Yes,
always very standard, I would say.
Yes, sir. So we are working on various attributes, and we will see that how it comes. One more question is it's from Dr. Bansal, sir, that how this can RDW can be used as a inflammatory status or for the chronic illness, rather than just differentiating between the anemia or the RBC size.
So this was a new
Sir,
question for me.
Before that, what is HSCRP and how often we use it?
Yeah. So CRP एक ही प्रोटीन है, C reactive protein, जो infection, inflammation, injury के बाद बनता है liver में. Now that is CRP. The normal value is up to 10 milligrams. And when we have more than 20 milligram, we consider that it could be infection, but it can be, even with viral infection, it can go up to 40 milligrams. But if it is beyond...
HSCRP is mostly written by cardiologists, and it is taken as a
I'm coming to that, So HSCRP is a very fine valuation, which is for values less than 10 milligrams. So if it is up to 1 milligram, 1 to 3 milligram, then about 3 to 10 milligrams. That is how it is counted as important for cardiovascular risk. But that is not relevant in our practice. The test is the same.
And now about this, sir, RDW and then NLR.
Okay.
Yeah. So RDW is basically a function of the size, variation in size of the red cells. In case of iron deficiency anemia, or in case of thalassemia, this variation is what I pointed out in my talk. Yeah, that is very clear. Now, in case of anemia of chronic disease, I will go back to that slide.
You have shown that slide, but what about its role in inflammatory states?
Yes, so in suppose we have a child with, I'll stop this. Yeah. So in case of anemia of chronic disease, you will have a microcytic picture. MCV will be low, but RDW may be normal. So that's, yeah. So that's a typical thing which will help you to distinguish between iron deficiency and anemia of chronic disease. So I'm not going back to the slide, but if you go back to the lecture, there is one slide on this differentiating between anemia of chronic disease versus iron deficiency anemia based on RDW.
Okay, sir.
And sir,
So, any other question from Dr. Banga sir? Banga sir or Ketkar sir, do you have any question in your sleeve for Dr. Bharat Agrawal?
There is one I can see here. Does micro ESR still hold?
Yes, sorry. This is the last question from Dr. Praveen. There's any role of micro ESR in sepsis screen other than the sepsis screen?
Yeah.
In the
So
era of CRP.
micro ESR is also ESR. Only the method is different. So it doesn't matter. What I mentioned about ESR is not specific, especially for neonates. It is not that useful. What you can get more information from CRP and from pre-cal would be definitely more important than micro ESR. Micro ESR was a method used when these were not available to us, and I would not rely on just micro ESR because it is a ESR. Just the method of doing it is using less sample and doing with the capillary method.
And this is one of the component of the sepsis screen. You have to fulfill whether more than 2 or more than 3 are present.
Yeah.
To say it's a clinically matching with or not. Sir, one question is on regarding the how frequently the CBC in low count in a suspected viral fever should be ordered.
How frequently? So see, first 48 hours, none of us order for a CBC. If it persists beyond 48 hours, you might ask. If you have a clinically well child and otherwise no other symptoms, and you're pretty sure that it's a viral infection. Once you find that there is some
okay, sir. And one more question. Sorry, sir.
Once you find that the counts are low, then if the neutrophil count is below 1,000, then I would definitely repeat the next day. If the platelet count is below 50,000, I would definitely repeat the next day. If they are in moderate range, I may repeat after 48 hours, but definitely repeat and confirm that they have returned to normal.
Okay, sir. Sir, one more question is regarding the PT tube, whether they are the citrate tube or something else.
Platelet
so
count.
Can we use this
Normally
PT
we
tube?
do in EDTA, but what I wanted to highlight was EDTA can sometimes cause clumping. So you cross-check with the peripheral smear, and if you take citrate, then the clumping doesn't happen.
Okay, good question, sir. So I think we finished with the chat box right now. Dr. Banga, Dr. Ketkar, sir.
How do you clinically differentiate between viral and bacterial infection using NLR?
See, more than NLR, I would recommend to check for the band cell counts. We have this, ratio also, more than 0.2 of band cells to mature neutrophils, which will indicate a bacterial infection. Now, viral infections can cause any change in the CBC. It can lead to lymphocytosis. We usually assume that it leads to lymphocytosis, but not necessarily. It can also cause sometimes neutrophilia. So just NLR ratio I would not rely upon for differentiating between viral and bacterial. We have to consider all other clinical picture as well as all other parameters, not just one.
Okay.
The toxic granulation, Dr. Bansal has asked one more question about the how much weightage you will give to toxic granulation in the
Definitely.
neutrophils.
Toxic granulation is definitely important. We don't see that often because of misuse of antibiotics, a lot of commonly used antibiotics. But if we see, definitely they are relevant, definitely. But more than toxic granulations, I just mentioned, the ratio of band cells to mature neutrophils. That's also relevant.
Okay, sir, two more questions, but I think it's already in your talk when to suspect the bone marrow suppression and what picture you will get in virus. So, sir has already said that you can get any picture in the viral infection. So, you have to correlate with the clinical and other parameters. Okay. Dr. Banga, sir, you are quiet now for since long. Do you have any question? Dr. Shobanga, sir? Okay, I think
Banga
he's
sir,
not with us.
just unmuted. Sir, you
Okay.
are not audible. बांगा सर आप ऑडिबल नहीं हो.
If
Please
Yeah.
please unmute.
if a CRP value comes high, how often we should repeat it? Because this test has become a test of commercial value. If you admit someone and CRP is not coming down, they will not discharge. So on the basis of that, they keep the patient, although clinical parameters have improved.
Absolutely foolish, I would say. Just, the CRP is a very non-specific protein, sir. It is, any inflammation, any infection, just the liver starts producing CRP. So it's not really such a specific thing to say that is. Of course, if the child is febrile and if there is clinically some issues or some radiological findings which you can which continue to remain, then I would be careful. But just because CRP is high to keep the child in the hospital is not justified.
सर भारत सर के क्वेश्चन को ही थोड़ा सा और आगे बढ़ा रहा हूँ कि आजकल सर बिल्कुल ठीक कह रहे हैं, ये बड़ा फैशन सा हो गया है CBC CRP टेस्ट लिखना, और अगर ESR नॉर्मल है पर CRP बहुत ज्यादा है, 150 है, ये है, तो how will you, I mean...
So one explanation I already mentioned, that ESR is lags. So you can have high CRP with a severe infection in the first 24 hours with ESR being normal or mildly elevated. It may not be severely elevated. So because ESR is a late acute phase reactant, you will find raised ESR beyond 48 hours, not earlier than that. But you can have very high CRP earlier part also. So that is the utility of CRP. That in early phase you can have very high values and you can detect an infection or suspect an infection, not detect on the basis of high CRP.
And sir, what is it?
So Dr. Bansal, as it is always said, that we don't treat CRP or blood test, we treat the patient. So a child should be seen as a whole, not just CRP or ESR or TLC.
Absolutely.
This is my take.
Absolutely.
We treat the patient, not the CRP.
Sir, second is, like if ESR and patient is improving, but CRP remains high in the range of 150 to 200, and suppose the other, like urine, I recently have a patient whose urine count, plenty of pus cells are there, patient is improving, everything is fine, but CRP has increased from 150 to 200. Should we continue with the same treatment or should we upgrade the antibiotics? What is the clinical significance?
CRP can never be a basis for your decisions in clinical. It's just a guidance. You can't take CRP as your reason to change antibiotics or to upgrade treatment or downgrade. As I mentioned in neonates, they have done that. 10 milligram से अगर ज़्यादा फर्क नहीं है तो आप omit कर सकते हैं antibiotics.
So should we take that after 48 or 72 hours of fever, we should not order CRP as such. It should only be ESR to guide us in a better way. Should we take it as a take-home message?
I can agree with that, because ESR is more indicating of global parameters, while CRP is a single protein. So, ESR is kind of a global assessment of the situation, of the inflammation, of the injury, of the infection. while CRP is a very specific single protein.
Right.
So just a single protein elevation, which is also not specific against a particular infection, not specific against a particular disease. We cannot rely on that for our future course of illness, course of treatment.
And sir, in megaloblastic anemia, when you have MCV higher, how often giving cyanocobalamin alone should be sufficient?
No, we have to. Cyanocobalamin is one of the causes of MCV high. So we have to be pretty sure that it's the only deficiency. If there is folate deficiency, we have to supplement. There could be associated. Very often we get mixed deficiency with iron also. So we have to give all three. Just one will not suffice. It's never, we always say, iron deficiency के साथ में protein deficiency भी होता ही है. So we have to provide protein also. It's not just iron. So
Right.
for the growth of the baby, we both are required.
Okay. So, sir, has no other question is left in the chat box. Now I will invite Dr. Kiran Agrawal, madam, for her take on today's webinar. And
Ajay, before that, Suhas has joined from Netherlands. He is again a key member in webinar. Suhas, welcome. Suhas Dhonde,
Okay.
unmute yourself. Probably he is not listening.
yes, sir. No issue, sir. We can take his comments also. Madam Agrawal, Kiran, madam. Yeah.
Yeah, thank you, Dr. Bharat Agrawal. I remember when I was developing the chapter of Indian Academy of Pediatrics on child abuse. I know you were honorary secretary at CIAP level, and I know how I'm very thankful to your support, immense support during that time. And thank you so much. And it's so well, actually, you have elaborated everything, and especially this ESR and CRP. There's no clarity generally. You have very well explained that. And it's nice to know you are so well recognized at the international level as well. And it's I'm really overwhelmed to see the GRMCNs, dear colleagues. It's just reminding me those days actually when, of course, there are not many when I was there. I was actually there in GRMC when these dacoits, they were surrendered on Mr. Vinoba Bhave's call. And they used to get admitted very often in JA hospital. And it used to be the villagers, they used to come for their darshans. And there used to be a long queue there. And some other violence also took place during that time. So I'm very proud of GRMC and what I learned there. And it's the unique thing was the senior juniors respect. Junior respects senior like anything. And whenever the two are there, it's our trend that seniors, they won't allow junior to pay for anything. So this was very proud of that tradition. It is going on still. And thank you so much for inviting me and joining me. Please let me keep in the loop. I would like to join this every month. I think you are having this.
Yes, madam.
In future. I would really like to be a part of it. Thank you so much.
Yes, madam. Thank you very much, madam. And we still remember that we have seen so many cinemas with the help of the seniors. We are standing outside the cinema hall and waiting for some senior to come, and then we will just say, good evening, good evening, sir, good evening, madam, and they are ready. Yes, so Suhas sir has joined. So Suhas sir, your comments, and then we will have another GRMC and Dr. P.D. Garg. Suhas sir. Dr. Suhas sir, unmute yourself.
Ajay, I have worked with Madam Kiran Agrawal when she was a DCA student there.
Carry on, sir.
And I was with PD Garg was my houseman for 2 years. He worked with me. So I have pleasure of working with both of them.
Yes, sir. Okay. Suhas sir,
Yeah,
unmute,
Bharat
unmute.
it's a
Sir,
long
we are
time that we
unable
haven't heard from you.
to see you, sir. Suhas sir.
अरे यार अब देखना बाद में सुना ही लो
सुनाइए हाँ यस
हाँ जी हाँ जी
सर हम देखना चाहते हैं ना एम्स्टर्डम कैसा दिखता है
हाँ जी एम्स्टर्डम में बड़ा अच्छा है भरत भाई दिस इज a long time that we have heard you.
Please. Yes, sir.
And it is really a pleasure remembering you having a one-to-one talk for such a long time for so many years. So it is again an eye opener to me. I was at the YouTube listening to you, but then I thought maybe yes I would at least say hi to Bharat bhai. Wishing you all the best, and it is really indeed a great pleasure to see Dr. Kiran, Dr. P.D. Garg sir, and all the stalwarts. Of course, headed by Dr. C.P. Bansal, as always, the thrust behind all the activities in Gwalior. Bharat bhai, we look forward towards similar interactions to make us wiser than before, as always. Thank you very much, Bharat bhai. Thank you, Ajay. Thank you very much.
Thank you, Suhas sir.
अजय भरत सर की थर्ड क्वालिटी है, 2 हो गई, एकेडमिक सबने देखा, एथलेटिक्स सबने देखा, और थर्ड क्वालिटी है, he is a person who call spade a spade on face. And I have several examples. When he was treasurer, he used to bluntly and directly counter the president on chair. When he was secretary also, and president was none other than Dr. Nitin Shah. He is only one person who can counter Nitin at that time. So hats off to you, sir.
Thank you, sir. And now I invite Dr. P.D. Garg, sir, who is a very favorite GRMCN. Old Boy Association is also having a very lot of contribution from Dr. P.D. Garg, sir. So can I have Dr. P.D. Garg, sir, now?
Hello, am I audible?
Yes, sir. Visible also and audible also, sir.
Good evening, everybody. Thanks, Dr. C.P. Bansal, Dr. Ajay Gaud, and all IAP team of Gwalior for making me part of this program. और मेरे को अपने पुराने कलीग से मिलने का मौका दिया. डॉक्टर बागा इज माय क्लास फेलो, डॉक्टर किरण अग्रवाल इज डिलाइट नाउ, गुड़गांव में रहती हैं, मिलती रहती हैं. डॉक्टर केतकर, he was like senior to me, 2 years senior, and he was my brother's class fellow, so I had a very good great affection, and we had a 90-day tour of South with Dr. Ketkar and Mehra. सब लोग गाली देते थे मेरे बैच वाले कि इतनी लंबी लंबी छुट्टी लेते हैं. We disappeared for 20 days. Now come to the point. CBC, we have started from the days when we used to get only hemoglobin, TLC, DLC, and ESR in our CBC. Nowadays, almost 24, 25 parameters are there to assist our knowledge. But there is a disadvantage. Now, most of the reports which we are getting are from the machine, hematologist, and no pathologists look at them. So we are missing the peripheral smear at all. I tell you, whether it is Renvexi lab, whether it is Lal lab, they are not giving any eye to the peripheral smear. They are just typing and doing digital signature. And we have seen that leukopenia is quite mixed in their reports. And whenever second, third report में कुछ जाके पता चलता है कि सब morphology is there. So I will request our colleagues to definitely send a sample to a place where pathologist looks into it. Don't send to a place जहाँ की collection होता है कहीं और उसको जो है analyze कहीं किया जाता है. Trust your neighborhood
very good
pathologist.
point. Yeah. Very good point.
Trust your neighborhood pathologist whom you can talk to. Don't believe on big names, corporate names. They are just making money by going into the public that we are so big and we are so much reliable. In case of CBC, one has to look into the microscope. Then only reports can be complete. This is my. Thank you everybody.
Thank you.
Absolutely.
Thank you, PD sir. And I am saying that
लैब में पैथोलॉजिस्ट है भी सही. ये बहुत सारी लैब है जिसमें पैथोलॉजिस्ट है
yes, sir.
ही
I am saying that Dr. Bharat is clapping. Dr. Bharat is clapping when Dr. PD sir is saying this. So can I have the last statement of Dr. Bharat on this issue? Sir, unmute. Yes, sir.
So I actually endorse what Dr. Garg has just mentioned. It is very important. If you see my first slide on CBC, it says that yellow and white. The white is the evaluation of the peripheral blood, which is missed out if you are not asking for the information or details. And it's definitely, when you send a sample to another city, it's not going to give you those kind of information. You don't even know who the pathologist is or to talk.
They don't look at the slides. They are not seeing the slides at all. You don't get any parasite over there. कोई मलेरिया नहीं मिलेगा, वो मलेरिया एंटीजन नहीं मिलेगा. सेकंड थिंग किस पे भूल जाइए.
हाँ, डॉक्टर गर्ग, क्या होता है गवर्नमेंट हॉस्पिटल्स में, क्या होता है any in emergency duties, if you just need, if you suspect something and you feel like having the peripheral smear, you send the blood sample. So technicians actually, they don't, pathologists are not on emergency duty.
Doctor sir, there is an answer for that. There is an
Only the
answer for
technicians are there. They can't see the peripheral smear. They
it
say
is everywhere. It is everywhere.
it will be done tomorrow, but that is missed out.
Listen to me. वहाँ पर ये होता है कि every sample which comes in the emergency or in the night should be verified in the morning, and then this authorization should be done. That is the only answer, and that is being followed at many hospitals. I know that we insist that provisional report should be given in the night, and in the daytime authorized reports should be delivered. This is the answer for that.
Okay, sir. You can talk to Madam 121 in Delhi. You both are now it is Delhi.
And this is for you also, that emergency
Yes, sir.
you don't
Yes, sir.
expect
Yes.
report from pathologist, but
Yes,
they
sir.
should see into
True,
one.
true. True, and it is endorsed. It is endorsed by sir also. Okay. So, yes, sir. So can we have now the last thing, Dr. Ghanshyam Das, Professor Dr. Ghanshyam Das, who is the President of Gwalior Academy of Pediatrics, for his closing remark and for vote of thanks. Dr. Ghanshyam, can you hear me?
Yeah, just a comment that all those who are interested in listening this presentation again, they can log on the YouTube and listen it again.
Okay. Yes, sir. It's a wonderful thing, sir, that you are doing it along with the Zoom. On this Zoom is also having the recording this session, as well as it's simultaneously going on the YouTube. I think it's a wonderful thing. So I think that Ghanshyam is not logged in. So can we have the Secretary of GAP, Dr. Karunesh?
Yes, sir. Good evening, sir.
Yes, Ghanshyam. Good evening. So just for your closing remark and for vote of thanks.
Yes, sir. Thank you, sir. Thank you, God, sir. Thank you, Bharat Agrawal, sir. Thank you, Karan Madam, sir. Thank you, PD, sir, for giving a wonderful talk on the CBC, which is very eye-opener for all of us. I think CBC is very important investigation for any patient or any diseases. Sir said very clearly about the basics of the CBC. Thank you very much, sir. Thank you, CB Bansal, sir. Thank you, Donde, sir. Thank you, Gaur, sir. Thank you, Gaur, sir, for making this event very useful and informative and fruitful Dr. Banga sir also, Dr. Ketkar also, for making question and taking all the pains for this very interactive session this evening. Thank you.
Yes.
Can I ask something about this?
Thank
When
you.
is this
Thank you. So
global
before
this global meeting, global meet of GRMC?
Madam, this question is not pertaining to the webinar.
Yes, madam.
You are already in the GGG.
Absolutely.
You ask this question in GGG, we will reply definitely, madam. So
Yeah.
before we wind up this webinar, I think we should acknowledge Dr. CP Bansal sir, just not for his effort of organizing this webinar, but taking pains for making the questions, the scenarios, and floating it in the Gwalior Academy of Pediatrics WhatsApp group. And everybody is taking interest in giving the answers. So I think it's a wonderful idea, sir. And though you are senior to me and you are leader, but yes, what I can say, sir, keep it up, sir. We all will follow you. Keep it up as a torch bearer for the Gwalior Academy of Pediatrics.
Ajay,
So
it's complete cooperation from everybody, and
that's true, sir. But at 11 p.m. you are floating the case scenarios, sir, for us.
मेरे पास भी क्वेश्चन
So I
आए हैं
think
रात को 11 बजे
the hats off to you for taking such interest. Yes, sir. Yes, sir. Sir की evening sir 11 बजे ही शुरू होती है.
the next guest in Gwalior webinar is Dr. Brajesh Udani.
Okay, that's wonderful, sir. Many of us just know by his name, and it will be worth to listen him face to face for the Gwalior Academy of Pediatrics. So with this, I think shall we conclude this, sir, so everyone can leave and enjoy the Sunday evening?
Yes.
Okay, so thank you very much once again to all of you, all the esteemed members of Gwalior Academy
Thank you,
Pediatrics,
madam.
our guest
Bharat
speaker,
sir,
Dr. Bharat,
thank you.
and all the
Bharat sir.
members of the webinar, Dr. PD Garg, Dr. Kiran Agrawal, for sparing this time. Thank you very much, and we will meet again next month with some new webinar. Thank you very
Nice
much.
to see you, Rashmi. Hi. Hi, Rashmi. Nice to see you.
Banga sir, thank you. Ketkar sir, thank you. Didi, thank you.
Thank you, ma'am. You can hear me. Thank you so much. I could see you here, and I remember your pearl necklace also, madam. Thank you for that.
Thank you. Thank you. Thank you.
Thank you, everybody.
Okay, bye-bye.
Okay,
Thank
bye.
you.